joining us this afternoon. I also want to introduce you to your presenters this afternoon. We want to welcome Ms. Candace Kugel. She comes to us from Migrant Clinicians Network. She is a family nurse practitioner, a certified nurse midwife. She has over 30 years of experience in healthcare. We're really excited and glad to have Candace join us this afternoon. We also have Ms. Hilda Bogue. Hilda is a licensed RN and certified as a health education specialist. She has a master's degree in health education and has a wealth of knowledge as well. So we want to thank our presenters this afternoon and welcome them. And I'm going to ask that Candace, I'll unmute you, Candace, and we can get started. Again, please let me know if you guys need anything throughout the course of the training. Thank you.
Thank you, Christina, and I hope everybody can. I hope everyone can hear me. I am delighted to be here this afternoon, and it looks like we're getting a nice turnout. So, thank you for taking the time to join us. And just at the outset, I will also thank you for the work that all of you do for our farm worker population. Starting out here with just a summary of our outline, and it's not terribly detailed. I think you can see that we're just going to talk about some of the basics about quality management and including your agricultural worker population in those activities, and we're going to give you as many resources as we can. Our objectives are listed here, and the presentation basically is going to provide an overview of quality management that's going to be talked about in the context of HRSA's expectations for health center grantees. And so there are going to be some references, for example, to some of the data that you need in your UDS report and to HRSA clinical performance measures. So you're going to be hearing a lot of very HRSA specific language. Hopefully my discussion isn't going to be too basic for those of you who've achieved some sophistication in your quality management programs. If so, hopefully you can share with the rest of us. We're going to be giving you some opportunities to do that, as Christina mentioned. We also want to be sure to give our presentation that emphasis on including QA and QI for your migrant and seasonal agricultural worker population. As Christina mentioned, I work for the Migrant Clinicians Network and have done so for many years. In addition to being a clinician prior to that, serving farm worker individuals. But I also should mention at the outset of this presentation that I work as a clinical consultant to HRSA. So I have done a number of clinical, been involved in a number of clinical activities with HRSA, one of which is being one of those scary people that comes to your health center to do reviews. So I just, full disclosure, wanted to mention that. This next slide lists the names of the HRSA Health Center Program requirements, and we did this just to give you the context of where quality improvement and quality assurance fits in. It is kind of highlighted there in red as number 8. And so let's move on to a definition of quality and quality management. And that may be something that we all kind of have a feeling for knowing what quality means. But in terms of quality management in healthcare, I like this definition, not just because it comes from HRSA, but because I think every word in this definition is important. first of all, well, let me read it. It says, quality is defined as systematic and continuous actions that lead to measurable improvement in healthcare services and the health status of targeted patient groups. So the goals of doing this work are to make either our services or the health of our patients better, or hopefully both of those things. And we do that through ongoing, which they use the word continuous, actions that are well thought out and defined, and that's the word systematic here. Targeted patient groups refers to what some people call population health, and the group being targeted is going to vary depending on the goal. It could be all of your patients if you're trying to improve your scheduling systems, or it could be your adult women if you're trying to improve your Pap test rates, or it might be all of your agricultural workers if you're looking at improving outreach services. So I will be using the term quality management as kind of an umbrella term that refers to all of this. There are a lot of other terms that get used and that I may also throw in. Quality assurance, or QA, is the observing, monitoring, data gathering part of quality management, like surveys and reports and graphs and charts. While quality improvement, QI, or PI, performance improvement, refer to the activities that are aimed specifically at making things better. So the QA/QI plan usually refers to a document that describes an organization's quality management program. And that leads us to our first poll question, which is, how familiar are you with your health center's QA/QI plan? And Christina's gonna help me with figuring out what your responses are. So if you see the poll there, we're asking you to respond A, B, C, or D.
You're going to have an opportunity, about 20 more seconds to put in your answer. Okay, we will close this poll. Okay, Candace, it looks like 61% of our participants picked C, that they're very familiar. 33% are somewhat familiar, and about 6% not familiar.
Okay, well, good. It sounds like we have the right audience here for people who do know something about quality management. So what we're going to do now is look at the wording of the program requirement that relates to quality management. So what I have on the next few slides is that HRSA language. The quality management program is expected to include clinical services and clinical management. And that means that the program should include quality assurance for all required services, regardless of whether they're provided directly or indirectly. So just as an example, let's look at perinatal care, which is a service that many health centers contract out. But since it is still a required service, if that's your arrangement, those pregnant women are still considered your patients, and that's why you're now being asked to report on and hopefully care about the outcomes of their pregnancies. There are some specific expectations about medical records policies and procedures that should be in place related to confidentiality, privacy, consent, storage of records, and archiving of records. And the quality management program is responsible for ensuring that those are in place. The organization's medical director or CMO or whatever you call that person should be the person overseeing and should be involved in the quality management program, although there may also be a staff person who is responsible for the real detail work of quality management.
Deliver quality and comfort to your home or office.
This section refers to quality assurance activities and references peer review and review of performance measure trends. Those are some examples of quality assurance assessments. Some others might include patient or staff satisfaction surveys, time studies, productivity reports, financial measures, clinical guidelines, things like that. These are all activities that in themselves do not necessarily bring about improvement. And I hope you like this little cartoon about peer review, about what peer review feels like sometimes. Sometimes it's a very collegial, benign activity, and other times it can be kind of threatening. So this wording refers to the fact that involvement of clinical staff is a must. And again, you see the word systematic there, meaning ongoing, which means that it's not collection and evaluation of patient records is not just once a year when the UDS is due. Patient medical record data is not the only source of quality management data, but it really must be included and should be central. So this next segment here gets to the quality improvement part of the program. And it can be the part that can take a while to get to, since setting up the quality assurance, QA part of the system can be challenging. And I like this cartoon because it kind of reflects the process of getting all that data together, making sure it's accurate, putting your electronic health record into use, and doing the peer review, writing the policies and procedures, and then it's kind of like, okay, now what? Don't forget this part. It refers to the process of moving on, setting goals, figuring out where improvement is most needed, and also recognizing where you're doing really well, and then embarking on improvement projects, and we'll talk about that process a little bit more later. So this slide just kind of summarizes the wording that I just went through that HRSA uses to define the expectations of a health center's QA and QI program. And we've talked about the plan, which usually refers to a specific document that describes your quality management program and activities. And that plan really can say anything, but let's just say, hypothetically speaking, that someone like me is coming to your organization from the outside. So what are some of the other documents that I'd be able to look at that would support your quality management program? So some of those are listed here. In addition to your plan, you may have a quality management policy and procedure. And there may be a lot of other policies and procedures like those related to medical records that we talked about earlier, risk management, patient safety, tracking, all those kinds of things. Job descriptions of the CMO and the quality coordinator would probably include some wording about their responsibilities related to quality management. And then there would be, hopefully, minutes of the QA/QI committee meetings, as well as board meetings that might sort of flush out the quality management activities that are going on, as well as data reports. There's always that UDS thing, the performance measures. You may also have patient satisfaction surveys, peer review reports, and hopefully performance improvement projects that show what activities are ongoing. So we promised at the start to talk about how to be sure your farm worker population is included in your quality management program. So before we get further into that, we'd like to have you respond to another poll. Does your health center include migrant and seasonal agricultural workers specific elements in your QI/QA initiatives? And I'm hoping for 100% on yes here.
Okay, we'll do about 15 more seconds. We have about half of you who have voted. Okay, Candace, it looks like 47% said A, yes, 33% no, and 20% don't know.
Oh dear. Okay. I didn't get that 100%, did I? Well, then listen up here to these next few slides. In order to be able to look at data related to any population, whether it's by age, gender, health condition, or whatever, you have to be able to identify them appropriately and accurately. And so if you're looking at your migrant and seasonal agricultural worker population, you can be sure to do that by regularly asking a few questions of your patients. Both MCN and NCFH have screening tools that provide an algorithm of just a few questions that are based on the HRSA definition of migrant and seasonal agricultural worker. So we would encourage you to implement one of those. And that way you can document and easily extract data related to that population. If your organization is serving a mixed population, and what I mean by that is farm workers as well as others, be sure you're including your farm workers when you're looking at your clinical performance measures. And that should be fairly obvious, but we have heard some organizations ask whether they can exclude them because either they're too difficult to count or they might make their data not look as good. So for organizations that receive targeted migrant funding, there are several UDS data points that have to be reported separately for that population, and I've listed those here. The UDS table 3, 4, 5, and 6A all ask for separate data that is specific to the farm worker population. Tables 6B and 7, for those of you who are super familiar with UDS, are the tables that include the clinical performance measures, and they do not ask you to separate farm worker data. And I just included the little note here that just because they don't require you to separate it doesn't mean that you don't have to. I mean, it may be something that you'll want to do just to look at that population as a separate group and see how well you're performing with them. So in addition to those performance measures and various health outcomes, as we all know, there are a variety of unique service needs of your farm worker population that you also might want to include in your quality management program. Things like language support services, transportation, environmental occupational health, and continuity of care. And this is where we'd like you to share some other population-specific points to consider when including migrant and seasonal agricultural workers in a quality management plan. So type into the chat box any quality issues that you may be including, or you would like to include, or you think should be included in your quality management program, and we'll see what you all come up with here. Don't be shy. Any ideas? I'm not seeing anything coming through. Am I wrong? No chats. Okay, well, I am going to move on. And
Candace, we have had Elizabeth shared that they include some evaluation of our outreach services.
okay, thank you, Elizabeth.
I looked at it immediately when you sent it to me, and I was like, yeah, I totally can respond to this. And then I like moved on to 10 other things, so I'm so sorry for not responding.
I think we have someone there. Thank you. Yes, definitely. Evaluation of outreach services is a great example. I included a few other things here. Feel free to continue to add things as you think of them, but I'm going to move along here. These are some points of other ways to make sure that issues related to your agricultural workers are included in your QA/QI program. One is to include relevant staff on committees, quality management committees, that is. And I have seen organizations where the Farmworker program is a small part of a much larger organization. And if there's no staff that's involved in the Farmworker program serving on the quality management team, then that's a good way to assure that those issues don't get addressed. And including the patients themselves, you can get their input through committee and board representation. You can do targeted satisfaction surveys, getting suggestions, focus groups, interviews. All those are ways to include their input. So, I see something else that Elizabeth wrote. For example, we assess people's comfort level with accessing a community health worker and what to do in case of an emergency. That's excellent. Emergency preparedness for farm worker
and has that expired?
populations is quite difficult. We have somebody that needs to be muted. So if you don't see that you're muted, please do so. Thank you. So some organizations, when the HRSA performance measures were first introduced, felt that those measures didn't tell the full picture of providing quality care for farm workers. So one approach to improving on that can be to, as I mentioned earlier, separate out your farm worker population for those measures from the rest of your population and compare them. And that might be a way to identify disparities. Another approach is to develop some population-specific measures of your own. And so I think it was 2009 when the measures were first introduced by HRSA, and there was a lot of concern about this at that point, especially on the part of the voucher programs, who were much more focused on enabling services than direct health care services. So in response, MCN was asked by HRSA to coordinate a project to develop some population-specific measures. And you can see the headline here of this was January, February 2009 in our streamline. we reported on the outcome of that work.
Any detail of
Interestingly, there have been measures that better reflect enabling services that have been added to the required measures since then. As some of you are probably aware, the number of performance measures that we're all reporting on has increased significantly. So there are some in there about BMI and nutrition counseling, tobacco screening, tobacco cessation counseling, depression screening, things like that. So there has been a little bit of progress there. And I just mentioned voucher programs, and they do, I think, deserve some special consideration here in terms of their approach to quality management. They're not all operating under the exact same model, but generally speaking, most voucher programs are organizations that serve agricultural workers who live and work within a large geographical area, and the focus is on getting people into care with contracted providers rather than providing that care directly. So this model kind of presents some unique challenges in terms of quality management, and that's what we've listed here. Things like getting the data back from those contractors about what takes place during a clinical visit, control over changing operations and services in an organization that is contracted. And then again, just that focus on enabling services as opposed to direct patient care. And another concern has always been the relevance of the financial measures. So in response to those kind of challenges, I think for voucher programs, it is important for them to develop some systems that allow them to be able to report on the required measures, since that is expected, challenging as it is, and also to develop some relevant internal measures that might be more helpful in terms of evaluating the services that are more core to the organization. And I've seen some voucher programs who make a good effort at including some of those contractors in their quality management activities, and that can be really helpful. So just to summarize, I'm going to circle back to a review of the elements of the quality management program. And some of these are a little bit beyond the HRSA definition that I talked about at the beginning. And I'd like to talk about each one a little bit and give you sort of a good news, bad news approach.
The U.S. has considered Cubans as not necessarily refugees, but they have the wet foot, dry foot policy.
We're getting somebody.
They have considered them refugees because once a Cuban reaches U.S. soil, they automatically become.
I'm sorry, Candace, if they don't accept their audio pin, I cannot mute them.
Oh, okay. Could you all please...
But I do know that for my sister's former family from Cuba, legally, well, like most Cubans do, if you don't come...
the person who's talking about Cubans, if you could please mute. Anyway.
So I don't know if he didn't tell them for work or whatnot, but I do know also that if you are not considered a resident of the United States and you're not being...
Okay, so what I'm going to do here is give kind of a good news, bad news
because you're not wanted here.
Assessment of each of these elements. And when I talk about good news, it reflects what I would consider to be best practices and not necessarily requirements. And the bad news column is elements that I would say reflect what I would consider to be signs of
that may have
problems.
expired and he wasn't aware of it.
So
at that point,
you can see under the quality management plan, under good news, it's something that's updated frequently. It includes all those measures you're looking at, identifies priorities, and has a calendar of activities. Under the bad news, it's something that maybe you can tell has been borrowed from elsewhere or has been written by a grant writer, doesn't really seem to reflect reality. Maybe it's not even approved by the board. And leadership may not even be familiar with it.
Yeah, because
I've put in here an example of a quality management calendar, and I love this because it shows you a very active and organized quality management program. It lists all the activities they're involved in and the months when they're going to be doing those particular activities.
He was incarcerated for robbing a bank or taking part in robbing a bank, and once he finished his sentence, they reviewed his immigration request for citizenship, and they said no, and they just sent him back to the Dominican Republic. And he's been here since he was 5. So,
is there any way to
like, what the hell do you do?
Notify this person who's talking? Please mute. Okay. This next slide looks at the Quality Management Committee, and again, good news and bad news. The committee hopefully has representation throughout the organization. It meets frequently, has good minutes that show reports of what's going on, and is well aligned with the plan. I'm always concerned when I feel like the quality management team is the same as the organization's management team, because that loses the opportunity to involve other people in those activities. And as I mentioned before, there may be no representation of special populations staff, and maybe no training about how to do quality management. This is an example of a committee meeting template for minutes. And this comes from the ECRI Institute, which some of you may be familiar with. It's an organization that has produced a lot of quality management and risk management tools for health centers. It's ecri.org, and this is just one of the many tools that they've made available. Looking at data systems, this is just a crucial area for quality management. So the good news is when there's a great electronic health record that's been in place for a while, everybody knows how to use it. There's been a whole process of verifying the data so that it's reliable. They participate in a network with other health centers that have the same EHR, and if an organization is patient-centered medical home recognized, that gives you some indication of their ability to do quality management. The bad news is when there's no involvement of IT and not really any expertise in the organization in that realm, and if the vendor for the health record is not supportive, that's problematic. This next one is probably the most important. You've all heard the phrase garbage in, garbage out. What that refers to is that if the data is not being entered into the appropriate spot, or if it's not entered at all, then your reports are not going to be accurate. And as far as electronic health records go, at this point 96% of health centers have some type of EHR, and 59% are patient-centered medical home recognized. So that's quite an achievement in terms of where we are with data management. Some of us are stuck here in the development of our data systems. We're using this pie chart, which maybe is not a bad place to be. but the level of sophistication with data management is often related to factors like the age of the organization, where they are in terms of EHR implementation, and just the amount of expertise in information systems within the organization. So the QA/QI reporting kind of builds on the data systems, and sharing the information is an important part of quality management, since you want as many people in the organization to know what's going on as possible. So good news is when I see all kinds of graphs and charts on walls within the organization, there may be a dashboard in place that's used to report to the board on key priority areas. But the bad news is when you talk to the clinical staff, ask them if they know what they're being measured on, and they kind of give you a blank look like, what's a performance measure? And then the other issue is where the data systems are all in place and there are all kinds of charts and graphs, but nobody's really looked at them to be able to move forward on the reporting, the improvement process. So here's a picture of one health center where they were very big on sharing data. So improvement projects, the good news would be being able to see lots of PDSA documentation, and I'll talk more about what that is in a little bit. There's organization-wide involvement in improvement projects. People can tell you what the priority measure of the day is, and it's all data-driven. The bad news is when the minutes say things like this quote that I have here: the high no-show rate was discussed. It doesn't tell you what that rate is. It doesn't tell you what the analysis of the problem is, or where the group is going to go as far as improving on it. And patients aren't involved. This is a form that can be used for documenting PDSA activity, and there are others, but this is one from the Institute for Healthcare Improvement. The last issue I wanted to mention is board involvement, and the good news on this one would be if there's a board member, or maybe even two, participating in the quality management committee, or the board itself may have its own quality management committee. That's often the case. And there's regular reporting to the board, hopefully by the medical director or CMO. And again, bad news would be when you ask the board members about quality management and performance improvement, you get kind of blank looks. One of the responsibilities of the board is to approve policies, and so in the area of quality management, there are a lot of policies, so hopefully they are approving those. So the path to success, what we always want it to look like is the one on the left, but in terms of quality management, it's more often the one on the right. And that's okay, as long as it's still going in the right direction, and you can see it's still continuous, but not necessarily direct. The next thing I want to do is, I don't want to take too much time on this because I think we're getting near our time, but I want to quickly walk you through a sample performance improvement project related to one of the HRSA clinical measures to demonstrate what it kind of looks like in action. And so I chose the BMI measure for kids and adolescents. And this is the way it reads. The percent of patients aged 2 to 17 who had evidence of BMI percentile documentation. And BMI is the height and weight, and percentile would mean that it's they get a percentage based on where they fall in compared to other kids their age. Okay, so it's documentation of percentile BMI percentile and documentation of counseling for nutrition and documentation of counseling for physical activity during the measurement year. So this is not simple from a data collection perspective, since there are at least 3 layers of data. And it's also important to note that the counseling needs to be done whether the BMI is normal or not. This is a measure that's relevant to our population, since childhood obesity is a concern for us. And so the process here, selection of the measure for this particular organization was done based on a population concern, and the recognition that it wasn't being done very consistently. They had looked at their baseline, which was their starting point, and they started this improvement project in 2012, and their baseline was 21% of their kids in that age group had a documented BMI percentile and had that counseling. So a task group was formed, and that included the quality management coordinator and staff who were involved in this particular service. So they included a pediatrician, a health educator, an MA, and an outreach worker. And they were assigned to this improvement project in 2012. So they looked at the measure to make sure they understood it, looked at what you would call contributing factors, restricting factors. Contributing factors are the things that are helping you to do well on this measure, and the restricting factors are the things that are getting in your way. So that gave them a little better understanding of where they maybe needed to concentrate their efforts. They set a goal of 50%. It was kind of conservative, but considering that they were starting at 21%, it would represent a big improvement. They decided to use the PDSA format for monitoring their progress. And so they tried a number of different interventions. The first one was to go to their IT staff, their information technology folks, and they looked at making improvements in the documentation fields for BMI that would, when you put the height and the weight in, it would calculate the BMI automatically and then give you a percentile automatically, so you wouldn't have to look it up on a chart. And they also put in a feature where it would indicate whether that percentile was out of the normal range. They adopted a new childhood obesity clinical guideline, and clinicians were advised to use it in their well child visits, and it was integrated into their EHR. They did education sessions of clinical staff, both providers and support staff, to provide a general update on childhood obesity and issues associated with that, as well as giving them resources for that nutrition and activity counseling that needed to be done, and informing them about how to document it, what codes could be used, and that sort of thing. They posted nutrition and activity signs in the exam rooms and all over the clinic, even the bathrooms. And they looked at data monthly in 2013 and then more frequently in 2014. Initially, they just started looking at the data for the pediatrician's patients, and then once they figured out which interventions were successful, they spread it to the whole organization. So PDSA, I did want to go into just a brief explanation of this because some of you may not be familiar with it. It stands for Plan, Do, Study, Act, and you can see a little circle on the left side of this slide. It is basically a series of small tests of change that hopefully are leading to improvement. And when I say small, I mean you just use you don't try it organization-wide, you just use a subset of your patients to try out an intervention on. And so that's the plan part is figuring out, okay, how are we gonna try to do better in this area. The do is trying it out on that small population for a short time, and that doesn't mean 6 months. That means 2 weeks or a month. And then the study means compare the data before you did this intervention to the after. And if it made a big difference, then the act part would be, okay, let's spread this to the rest of the organization. If it made no difference or just a little bit of an improvement, then you may want to go back to the plan section there and figure out something that might be more effective. So the little graph on the right-hand side shows you a kind of a continuous process of going through that PDSA cycle over and over and over, and hopefully leading uphill to changes that result in improvement. So there are other methods of improvement. Lean and Six Sigma are a couple of them. You don't have to use PDSAs. It is a methodology that's very prevalent in health centers, and it's easy to use. But I just wanted to give you a little bit of background on that. So this shows you the outcome for this particular organization. Their progress is represented in this chart by the lighter blue bars. So in 2012, when they started out, they were at 21%. They went to 46% in 2013, and in 2014 they got up to 89%. The other bars, the dark blue is their state, and the orange is national. We don't have state and national for 2014 yet. So they had set that goal of 50%. They almost got to it. In 2013 they were at 46%, and now at 89 they've completely revised the goal. They've now set it at 90, and they're nearly there, so they're monitoring the data now every 3 months. So that's what you'd call a successful improvement project. Hopefully this discussion has stimulated some thoughts about how you can do QA and QI in your organization and with your farm worker population. We'd like to hear if you've come up with any ideas as you've been listening, or if you have experience with any farm worker specific quality management initiatives that you're already doing. If you would be willing to share those. And we'll go ahead and see if anybody has anything to input there. And then we're going to move on to reviewing some of our favorite quality management resources. And I'm going to let Hilda do that. So, Hilda?
Hilda, you're unmuted now.
Thank you. Thanks, Candace.
Mm-hmm.
then I cannot turn the, here we go. Okay, well, thank you very much, Candace, for such wonderful information. After hearing about quality assurance and quality improvements, its elements, and the inclusion of farm workers in the quality assurance plans, let us talk about some resources where you can find additional information on that topic. First of all, we suggest that you go to the HRSA webpage, where you can find this, under the tab of program requirements, you can find all the information about the program requirements, including the one we are talking this morning about quality assurance, quality improvement plan. Also in the same page, you can find this site visit guide for community health centers. This is a very important information. Sorry, I think it went. This is a very important information or document that you could very much look at it and see and study basically what is included in more of a length, or what Candace talked about it. Also there, thank you, also there you find the Cooperative agreements, and in that web page you can find all the national organizations that are partially funded to provide services to some special populations. For example, you can find there the Farmworker Health Network, in which both the Migrant Clinician Network and the National Center for Farmworker Health are listed in the category of migratory and seasonal farm worker technical assistance. There is also another resource for you, and it's also under the technical assistance tab, and it's called the Resource Center for Samples and Templates. In that place, you can find a robust section of templates, tools, and sample plans that you can download and use and modify according to how you need it. Next, I will direct your attention to this web page, which is the National Clinician Network Health Network also. What it is a national program that provides patient navigation services, specifically for the hard-to-reach population, such as the migratory and seasonal agricultural workers, as well as other migratory groups. Because this network provides case management, it can help your health center assuring the continuity of care and the treatment completion of those patients that are enrolled in this program. So Candace, do you want to elaborate a little bit more about how it works?
Yeah, I felt like it was important to include this here because, as Hilda just mentioned, it does provide you, if you enroll a patient who is about to move away, then it ensures that they stay in care when they reach a new location. And once their treatment is completed, for example, a pregnant woman, you will receive outcome data as long as we get it from the other providers. So it can help you with reporting on your data.
Thanks, Candace.
Sure.
All right, the other resource, and Candace referred to it for a few minutes, is this one. HRSA actually contract with the ECRE Institute to provide quality improvement, training, and technical assistance for those health center grantees. We encourage you to visit this webpage. There are several quality assurance toolkits. You can also read electronic news and participate in the webcast. Some of those services are available to everybody, but there are some that only health centers are able to access, and you will need to have your 330 number in order to open an account in this organization. Other resources that are there for visit or for consulting is the Primary Care Association. Some of them do provide technical assistance in the area of quality assurance. We also encourage you to visit other agencies, such as, in this case, listed the Agency for Healthcare Research and Quality, the Robert Wood Johnson Foundation, the Migrant Clinician Network, and other listed organizations here. All of them offer excellent information and quality assurance, and provide you the opportunity to sign for updates on those topics. We hope the shared information can help you when you are developing or revising your quality assurance program and considering to also include agricultural workers on it. Our contact information is provided at the end of this presentation, and now we invite you to send us or ask any related questions that you may have. Christina, can you please take over?
Absolutely. So as Hilda mentioned, if you have any questions or if you jotted down any questions during the course of the training and presentation, please feel free to shoot those through on the chat, and I will read those questions aloud.
Well, it looks like we aren't getting any questions. So for those of you who, I know we're at the end of our time now, so we'd like to let you go ahead and sign off. And feel free to contact either of us if you would prefer to do that by email. And best of luck to you in your work and in quality management. Thank you again.